This is case 20, and this is an example of what happens when you take a piece of gout from a gouty tophus, and instead of putting it in formalin and doing regular tissue processing and H&E staining, instead you put it into alcohol, ethanol, and fix it with ethanol, and then cut it and do not apply any H&E stain. And what we get here is a aggregate of gout crystals that have not been dissolved. And so that's why it's totally pale, because we don't have any H&E stain applied. And if we go closer, you can see these areas here, they have a brown, this squiggly line is an air bubble. And the reason there's an air bubble here, air bubbles happen because there's not enough mounting media between the cover slip and the slide. And often that happens, sometimes that happens due to defects in the cover slipping equipment. But other times that can happen if you have something thick that didn't cut as thin as a normal tissue section, which we normally cut around 4 microns. And thick things can mean bone calcification or foreign material that did not cut well, and so it left a thicker layer, and that pushed the cover slip up and left this air bubble because there wasn't enough mounting media to fill the space in. So sometimes if you see big air bubbles like this, it's a clue that maybe there's something hard and potentially either foreign, crystalline, or calcified, or bone in your specimen. So you can consider going to look for that to see why, okay? And here, look at the other clue is that the color, everything else is clear, but this area is a brownish, grayish, black color. And if we go in closer, and this won't show up well here, but it really shows up well on a light microscope where you can flip your condenser, and well, here it actually is showing decently. You can see there's a refractile nature to these this material. These are crystals, and these crystals have not dissolved. So whenever you're thinking about gout and you see an area of grayish, brownish, black coloration and a more refractile appearance, especially if you flip your condenser, you can really highlight that three-dimensionality. It looks like it stands out from the tissue. I can't really show that, or those are words I'm trying to explain, but you got to see it with your own eyes on your scope. Oh, you know what? You can actually see it right here. See how this tissue looks like it's kind of 3D. It kind of is out of focus even more than the rest of the tissue because it's kind of coming out of the tissue at us. It's a little thicker, and so it's not focused as well as the rest of the tissue. And you can see the needle-shaped kind of appearance here. So these are gout crystals that have not dissolved. And if you put the polarizer in, they'll glow brilliantly. And if you go to my Kiko index, or I'll try to remember to put a link down below, I've got some nice examples of what the polarized gout crystals look like on a smear. And I've got another gout video that shows what they look like on a sample kind of like this. Okay? So anyway, ethanol fixed and unstained section of gout. And sometimes even in regular formalin fixed and regular processed, regular H&E sections, you'll see little fragments in the middle of the pink nodules of gout. You'll see little areas that look this color. If you do, go and put your polarizer in and polarize it, and you'll be in for a nice treat, because polarized gout, as terrible and painful as it is for patients, it's quite beautiful microscopically, and I think anyone could agree about that. So in any case, sometimes a little bit of gout, even if you don't do this special processing, sometimes a little gout survives the processing and staining, and will show up like this little black or gray fragment on the regular H&E section, and that area will be the area that will polarize. All the stuff that looks pink like fluffy clouds or cotton candy, that stuff's gone, and it will almost never polarize. But the areas that look refractile and grayish brown, those are areas that are still left over gout. And the reason I think they're grayish brown is I think there's even without a big air bubble, I think tiny little bits of air get in there, and that makes the tissue look a little refractile and makes it not look at this darker color. Because actually when you focus in, the crystals are not actually dark colored. This is just an artifact of three-dimensionality and air and not focusing correctly. Some combo of that, it gives the light, makes it look kind of blackish, but it is actually not. These are not pigments in crystals. Just wanted to clarify that, because I know here they look like it, but they're actually not. It's just an artifact of the way the light is refracting coming through the slide. All right. Okay, so here's an example of a smear from gout that's either was air dried or fixed with alcohol. I usually just like them air dried, honestly. And then when you polarize it, you get these beautifully birefringent, thin needle-shaped crystals. And you can see that in some areas they're haphazard, but in others you can see how they're kind of arranged in like a bundle, like a sheath of wheat, like in the old-timey days where they would wrap wheat together standing up in the field. I think that's where the word sheaf came from. I don't see wheat ever really done that way anymore, at least not where I live. But in any case, this bundled package of crystals here is, you can see that, and then if you go look at the pale pink areas on an H&E section of gout where the crystals are washed out, you can kind of see the shadow of this same appearance of multiple stacked collected bundles of crystals haphazardly stacked together, and then that's what gives that kind of appearance, okay? So that's a nice example of what polarizable gout crystals look like. Case 21 is going to be a nodule that is often clinically they're either thought to be a cyst, or sometimes because they have a kind of chalky white appearance, the dermatologist might recognize what it is if they're close enough to the skin surface. So this is an example of pilomatricoma or pilomatrixoma. I like how it looks better with the X when you write it, but it's easier to say when you put a C in and say pilomatricoma. Both ways are totally accurate. This is a benign hair follicle tumor, and it is recapitulating what happens in the hair root or hair bulb. So what you're going to get is blue basaloid matrical cells in some cases, and then those will transition into sheets of keratinocytes that are starting to die and have dissolving of their nuclei. So they leave just a shadow of the sheet of keratinocytes. So we call these shadow cells or ghost cells. You can see the shape here. There are lots of little keratinocytes arranged in a sheet, but they don't have any nuclei. They're just pink. The keratin is left, but the cells are dead and the nuclei are gone. And what's happening is just like the normal hair follicle, the blue basaloid cells at the base produce keratinocytes that eventually die and get packed together. The keratin's packed together into a hair shaft, and that's how our hair grows. It's a normal process. The keratinocytes are supposed to die. So the same thing is kind of happening, but in a much more disorganized, haphazard way in this benign hair follicle neoplasm, pilomatricoma. Okay? In this case, we don't see any blue basaloid cells. Let me look around at low power. All we see are the ghost cells and the variable reactions to those ghost cells, okay? So some cases have abundant blue basaloid cells and a lot of mitoses and look very scary, but they're totally benign. But it's good to go and familiarize yourself with that. I've got some whole slide examples and videos about that on Kiko. But a lot more often what I see is this kind of pilomatricoma, where we just have the ghost cells and then they're all arranged in disorganized fragments. They're a nodule from low power that's usually pretty circumscribed. And then at closer look, haphazard, mishmashed, rearranged, or I'm sorry, I don't know what the word I'm looking for is. Haphazardly arranged or mishmashed, some people would say, fragments of ghost keratinocytes, dead keratinocytes with variable amounts of calcification. Calcification is very common in pilomatricoma. Sometimes it's focal. Sometimes it just starts to make like little rings of calcium around the sheets of dead keratinocyte ghost cells or shadow cells. So you can tell the shadow cells, which normally look kind of a pink or orange, or as some of my residents like to say, they like to say peachy pilomatricoma because it has a kind of peach, orangey pink peach color. And I like that. The keratin actually really does often have this kind of peach color. I don't think I was ever taught that, but my derm residents recently, a couple of them taught me that, and I'm appreciative because I think that's a beautiful terminology. So peachy pink pilomatricoma, and then that pink color starts to turn more and more blue and purple as calcium deposits on this dead keratin and eventually makes thick, fragmented, cracked aggregates of calcification. And sometimes that can even progress all the way to metaplastic ossification or heterotopic bone formation, okay? The reason it's good to know about this calcification or ossification is when it's abundant, beginners who have not seen this phenomenon before will look at this and think calcinosis cutis or tumoral calcinosis because it's islands or pools of fragmented calcification with fibrosis, and oftentimes you'll get some giant cell histiocyte granulomatous type reaction around these islands, okay? And so you'll think calcinosis cutis. The key here in telling this apart from calcinosis cutis is to go down and find those islands or those sheets of shadow cells or ghost cells, the keratin content, okay? That's the key. Once I see those, this is not calcinosis cutis. This is a calcified pilomatricoma, okay? And or if you find sheets of blue basaloid cells with some mitoses, that would also be evidence that we're dealing with a pilomatricoma that's calcified. I don't think this case has bone. I have some other videos that show examples of that online, but if you have abundant bone, you might think it's an osteoma cutis. Again, if you find blue basaloid cells or you find the peachy pink sheets of ghost shadow cells, then you know it's actually a pilomatricoma with bone formation. And oftentimes the ones with bone also have calcification in them. And here's some area of the giant cell reaction. Pretty much all pilomatricomas seem to rupture and get disorganized fragments, and that usually in all the spilled keratin contents into the dermis. The dermis does not like keratin to be loose. It's okay to be inside a cyst. It's okay to be in a hair follicle. It's okay to be on the skin surface. But once it gets loose in the dermis, it is contacting naked dermal collagen. The dermis reacts with, the immune system reacts with a kind of explosive mixture of granulomatous response, and you'll get histiocytes, granulomas, giant cell reaction all around the keratin, and fibrosis too, okay? So that's why a ruptured cyst will provoke such inflammatory response and granuloma formation, because the dermis and the immune system do not like free keratin for some reason, even though I don't know why. The keratin's harmless. And the same phenomenon happens when you get a pilomatricoma. This one has actually very little granulomous response. Some of them have a lot of granuloma. And the other thing I wanted to point out is that from low power, they're usually circumscribed. But when you get a fragmented biopsy of a pilomatricoma or a punch biopsy of pilomatricoma, it has the appearance of infiltration because it's so haphazard. And so especially when you get that plus blue basaloid cells, people start getting worried that it's malignant. And especially when you see mitotic activity. Again, this case does not show that, but some cases do. And it's important to see some examples like that and to recognize that those end up almost always being benign. There is a malignant variant of pilomatricoma called matrical carcinoma, or a malignant pilomatricoma, or various other names. Those usually have marked atypia, atypical mitosis. That's the thing I'm looking for. They usually look obviously malignant, not like pilomatricoma. Usually they have focal pilomatrical areas, but look really like a malignant high-grade tumor in my experience. I have only rarely seen them that looked like pilomatricoma at close-up, but because of clinical or because of extensive infiltration away from the main mass on excision, that it was clear that they were malignant. But usually they look obviously ugly in my experience microscopically. In any case, that's more detail than you need. This case, no one would ever confuse, I think, with malignancy, because there's like no viable cells here. And then, oh yeah, also you can get, there's some slit-like keratin spaces. Cholesterol granulomas look very similar to keratin granulomas to me. I'm not sure which this is, but I would vote that it's probably a keratin granuloma because we have all this free keratin around. So there you go. Calcified pilomatricoma.